Morning, Bindy. Tell me about yourself.
Good morning, Matt. My name is Bindy Sahota. I'm a consultant ENT head and neck surgeon who specialises in thyroid robotic surgery and paediatric head and neck primarily.
Thank you very much. And tell me about your exam history.
So I'm a bit of an anomaly. I'm an ENT surgeon now, but I didn't start out that way. I've actually held 4 different training numbers in my time in orthopedics, general surgery, ENT, and academic ENT. And so I've actually had an unusual career to get there. And when I started, I was a what's called an MTAS baby, in that this is a time and of a bygone era that most people nowadays won't even be aware of. So in 2007, when they introduced foundation years in F1, F2, which was 2005 to 7, 2007 came as this kind of massive change to the medical curriculum in the UK. In effect, it was a rebranding, and I was one of the lucky people who got training numbers in general surgery and so on. Um, so my career at that point in time was very much driven going into general surgery and the exams associated with that. Um, Along that pathway, I had a few hiccups, which I'm going to talk about in a minute, I'm sure. And then actually after a few years, I realized what I really enjoyed, or where I enjoyed being, was in the neck primarily, rather than in the abdomen and the neck occasionally, which is what has led to me to be where I am.
So tell me about the hiccups then.
Well, I was in this unusual zone where I was allowed to sit either the new MRCS or the old MRCS, and I'm sure most people are aware of the new MRCS. So the new MRCS is OSCE based. The old MRCS, which yourself and myself will have sat, was based on 2 writtens, and then going into what are called vivas, where you examined on 6 different topics and they were paired with multiple different people. I went into this, and then once you clear that, you then go into clinical skills, which is split into 4 different specialities, and then there's com skills. But I remember at the time I'd been really organised, and in F1 I did the first part of the exam, F2 I did the second part of the exam, and then I came to my CT1 with my run-through job in general surgery, and I was like, what do? Do I sit the new type or do I sit the old type? And everybody was criticising the new type, saying it's simplified, and to cut your teeth, you want to sit the old type. Foolishly and maybe non-selfishly, I said, "Yep, I'll sit the old type." So I went to the Vivas, and I was probably 8 months into my CT1 year, and I was doing fine. I had no issues, and I just turned up to the exam, and I was like, "How hard is this going to be?" And I turned up to the exam, and I got absolutely eaten alive. And it's just because I didn't know any formatting, I didn't understand the structure. I literally just turned up, and I got, so they were marked basically a very similar way to the FRCS. So a clear fail, borderline fail, pass, excellent. So in effect, 4 marking streams. And I got a clear fail on pretty much a lot of them, and I got a borderline on just over half of them. So yeah, I learned very much the hard way. That's not the way to prepare for an exam. So what did I do as a consequence of that? While doing general surgery with HPV and vascular, with very busy jobs, I then sat down to re-revise for the second part. I absolutely don't think I've ever worked harder for an exam in my entire life. And I remember getting to that exam, getting through it, and I thought that wasn't too bad. And the second time I sat it, I got 5 passes and 1 borderline. So technically, I was under the threshold to pass the second time. The second time, I failed again, having spent 6 months of my life absolutely chained to work. So working during the day, 14-hour days, coming home, working 3-4 hours every night, spending my weekends, and truly devoted. And I realised, what on earth am I doing? Am I actually going to be able to do this? Can I get through this? And I genuinely thought about packing in medicine, which is quite a bizarre place to be, 20 years later almost, to actually tell people this out loud. It's really quite demoralizing going into an exam that you've prepared really, really very hard, and you've given up lots of social functions, life things that you normally do in your mid-20s to sit down and revise. And I had to spend a lot of time speaking to a chap called Mark McCarthy, who was the old head of School of Surgery, who was one of my mentors for vascular surgery, and he really brought it down to line and calmed me down, reorganized my thought process. And what I realized was, when you're going to a professional exam, you need to have an organized structure. So all exams will have some sort of format that you will need to follow. Yeah. And this is true for the FRCS, the MRCS, DONS, any of them. Yeah. There's a syllabus for them all. The syllabuses sometimes aren't overtly obvious on the outside, and they often can be quite hidden, but you can get hold of them online. And then I prepared for my next set of exams, and I went for my third round of the MRCS fivers, and I paid the college, and this was back in 2008 going 2009. I paid the college £2,000 to go sit their course to pass the MRCS. And the funniest thing is, you go to this course was set up at the time. It was on for 14 days in effect. So it was on from like a Monday to the following Friday, and you had the weekend off in between. So sorry, it was 12 days, with a weekend off in the middle. And I went down to London for 2 solid weeks, paid £2,000, let alone the accommodation, massively over my budget, all came out of my own money. And you're examined by the examiners. And the head of the examiners, a chap at the time called Vishy Mardavan, who's a reader in anatomy, was there vibing me, and literally in the middle of the vibe went, "Why are you here?" And I went, "I have no idea." And he went, you should have passed this last time. Like, your knowledge is impeccable." But what I hadn't realized, and that's when Prof. Mardavan said that to me, what I'd realized, what was always off was my exam technique. And it was the exam technique to deal in a Viva situation. And as horrible as it was to end up going through 3 sets of Vivas to eventually pass, and on my third time when I actually passed it, I scored high enough for the gold medal for the MRCS, but I wasn't eligible because I'd already failed it twice. I missed 1 mark in the entire exam on my third sitting. And that was because I hadn't figured out the rules of engagement, hadn't figured out the syllabus, hadn't figured out how to actually answer or address questions. It was amazing when I passed, genuinely amazing. But it was a hard time to get there, and it was socially and emotionally turmoil along the way. But it was worth every part of it, realistically, because it taught me how to deal with Vivas well in advance of sitting my FRCS, which realistically is your endpoint. If you want to be a consultant surgeon in the UK, you will sooner or later need to do with the FRCS. By having all that turmoil actually helped generate my style and processing for the Vivas. And then when I came to the FRCS, I found I didn't have to relearn the technique because I already had the technique from the times I've got it wrong, basically. And actually, for the FRCS, it was a lot more straightforward because it was organizational rather than in regards to information, rather than thinking about, oh, how do I address this question? How do I deal with this problem?
That's quite a story, and an awful lot of learning there.
Well, I was going to say, I don't think you ever realised how many times I failed my MRCS.
I don't think that I ever knew that. Nor did I know that that you were almost an MRCS gold medalist. Of course, I knew that you're an FRCS gold medalist, which is why I invited you to talk about giving other people tips on passing the exam. So, and it sounds like there's lots of tips there. So maybe if we go back to the beginning, so the first time round, it sounds like you just didn't work, sort of you turned up to your clinical practice, you enjoyed surgery, you enjoyed clinical work, you were doing well as an SHO, and there was an assumption there that's going to be enough to pass the exam. Does that sound fair?
That is spot on rather than fair. That is precisely, I was a jobbing SHO who was doing a good job, and I was getting positive feedback, and my tabs, my 360s, they were all great. But that's not how you pass an exam.
Okay. So the first message then for anybody listening is that exams are not the same as your clinical practice. And, you might be brilliant at clinical practice, you might get brilliant feedback, lovely patients, lovely colleagues, lovely operating, but actually that isn't how you pass the exam. So, and I heard you say that exams do need hard work. Is that fair?
Yeah, I think it's about rules of engagement. and somebody said this to me at med school actually, that if you don't know the rules of an engagement for an exam, it's like playing a sport, isn't it? So if you go out and play rugby or football, and so in football you're not aware of the offside rule, if you turn up and you're like, oh, I can get in front of that person, they can kick the ball to me, then yes, that's the obvious way of winning, but it's not the way to engage with the sport, is it? And neither in rugby can you go hit somebody who hasn't got the ball. Both those maneuvers would probably help you, but actually they're not the rules of engagement. So an exam is like a sport that you have to know the rules that you need to play by and follow to address them in the order. It's kind of like going into a court. You can't just butt in. You can't not address the judge appropriately. You can't be impolite with your answers. And if you don't know the rules of the engagement in any scenario, and the exam is probably one of the most professional scenarios that you're going to be in, then you're automatically going to fail, aren't you?
So what are the rules of engagement in postgraduate exams?
So there's the pre-prep. So that's the preparation before you even turn up for the exam. So what I mean by that is knowing what are the topics that you can be asked on. Yeah, there is only a finite number of topics that you can be asked on. Yes, they seem infinite and they seem massive when you're in them, but these will always have some sort of element or design. So for the FRCS, for any FRCS, this is in ENT, general surgery, etc., you have a document called the Gold Guide, which is easily accessible by Google. And if you type in the Gold Guide and you type in your specialty, you'll be able to see this. Now, it is a bit of a laborious thing to do, but what you can do, and I did this, and I have a list that I've shared with you, Matt, where I went through the entire Gold Guide, and I went through the actual syllabus, and I went through every single point that there is in the entire exam. And I think my list is, I think it's about 110 points, yeah, which sounds like a massive amount, but actually they're just topics that you can talk about. And realistically, you can't go much further off-piste, as in the examiners, the people who write the questions, can't really go off-piste from these topics, because they have to involve them, because they are the core bits of knowledge that you should know to get to the end of your specialty. Obviously, this varies. The Gold Guide gets updated every few years, so do keep an eye on it. And I'll give you an example. Vascular surgery used to be part of general surgery. Now, vascular surgery don't have any thyroid and endocrine. So depending on your sitting, things do change. So make sure you do keep an eye on them. Generally, for our specialty in ENT, you're not going to get a vast amount of change, because we don't tend to lose things, if that makes sense, because nobody else really wants ears or noses, realistically, in the grand scheme of things. So that's your pre-prep. In regards to what you actually do, so I would probably say 6, maybe even 8 months before, go through that syllabus, identify those points. I then made what's called a mind map and a mind node, which I've shared with you. I then printed it out on a piece of paper. And when I say piece of paper, this wall here on my side used to have this mind node on, and it was 6 A4 pieces of paper vertically and 5 horizontally. So it came over 30 pages. And I stuck it on there so it was easy to read. Everything I went through a topic, I crossed it off. Yeah. And then that way I knew I'd covered the entire syllabus. And that I did realistically over about 6 months. You want to give yourself 6 months. You don't want to give yourself more time. If you give yourself more time, you will end up just tired, and you will start to struggle, because it ends up becoming like a war of attrition. So I think there's a gold number, and it's kind of 4 months to 6 months. Anything kind of under 4 months, you're probably cutting it a bit tight in regards to your knowledge, unless you really have got a true impeccable photographic memory where you can look at something and just understand it and get it. But most people aren't that. We're in a bell distribution as medics. We might think we're amazing, but most of us aren't. Most of us are average medics. And that's what I'd say as a whole. Then what you want to do is you want to plan your sessions in regards to the organization that you're doing. So when you're coming down to the writtens, there's lots of banks of questions. Most of them are available online. Lots of companies, or you can kind of log onto websites and get them. I know Pass Test do them for general surgery and so on. And there's lots of banks. Your senior registrars will be an absolute phenomenon, and your junior consultants of these banks of questions, and most of them will probably have them already physically, and it's worth getting hold of them so you can start going through them. When you start going through banks of questions, you don't want to do too many, because your brain will kind of seize up after a little while. So if you've done more than 2 hours of banks of questions, then you've probably done too much in a singular sitting, because your brain does kind of get overloaded, even though they're very tiny, fine bits of information. Then you can get overloaded. What I'd find is I'd answer a question, I'd look at it, and so in the EMQ, so the extended match questions, you'd have some sort of statement, and then you'd have 5 or 6 kind of answers. If it was really obvious and I got it straight away, I would just move on to the next question. If I got it wrong, I'd then confirm what the answer was. I would then circle that question and I'd put it aside to then, when I come back later that evening, so once I've done my 2 hours of questions, I'd come back and I'd read about that topic. So I wouldn't just figure out the answer, I'd just read around it so that I understood a little bit more around the periphery. I hope that kind of makes sense of the organization.
Yeah. You mentioned that you drew out the curriculum for you and then you went through it and crossed bits and pieces off. One of the things that I sometimes hear is that people will pick a topic and then they're going to realize there's real depth to that topic, and then they spend 3 months reading about the left ear anatomy and then discover they've got 2 months left to read about everything else. I mean, what's your tip for apportioning time to the relevant topics?
So what you've said is 100% right. That is exactly what people do. The other thing is people often start with the topics they are happiest with. So oddly enough, for the FRCS, the topic I was happiest with was PEDS. That was the thing I was most comfortable, considering I predominantly do head and neck. PEDS was my go-to session. So a lot of people, let's say if they want to be an ear surgeon, they'll end up doing ears, and yes, they'll learn the minutiae of something. That is a complete and utter waste of time for everybody. Now, what you are better off doing is choosing the topic that you are worst at, starting there. And that is precisely what I did in regards to the FRCS prep. I started with rhinology and facial plastics because I highlighted that as my weakest portion. It allowed me to then go through that, deal it up into kind of little aliquots, read around the periphery. Then when I went on to ears, which was my next topic, then I got onto head and neck, and then I came back round to PEDS because that's where I was happiest with. And then by the time I cleared it, I knew I had about a month left. It actually allowed me enough time to go back to rhinology and redo it in more detail. So that's what I kind of look at it as a whole. I don't think you need to know the absolute minutiae of everything. You need an overall breadth of being safe, and your FRCS is there to test you on one specific function. Are you safe as a first day consultant? Nothing more, nothing less. That means, are you safe to be on call? Are you safe to have a registrar you can supervise? Are you safe to deal with an emergency there and then? You do not need to know how to physically take out a glomus tumor. Neither do you physically need to know about this minutiae of the amount of pharynx that you need to be able to do a primary closure versus a complete reconstruction versus which free flap you may specifically choose, or why you could use a temporalis fascia flap for a vertical partial laryngectomy. They are minutiae of super specialized knowledge. And that's kind of the fairest way I'd say about it.
So I guess people need to know that those are questions and those are controversies and those are discussions, and people need to know that you can't just take out the pharynx and at some stage you might need to reconstruct it, or not, and likewise that there is such a thing as glomus, and you need to be able to spot it and recognize it, and refer rather than, as you say, manage it.
Yeah, 100%. I think the problem is human nature and normality to go to the bits you're happiest with, because it reassures you. Oh, I want to do ears, and therefore I'm going to talk about CSOM, or I'm going to talk about cochlear implants, and therefore you get this association, and you go, oh, I know this, I'm happy. And when we talk about vivering, which I'm sure we're going to in a minute, That is one of the flaws that happen in Vive groups, actually. But we'll come back to that when we get to part 2 stuff, I'm sure.
Yeah. Okay. So let's think if we stick to the journey. So somebody's making a decision and they say, okay, I've got an exam coming up. So where we are so far is they've got to be prepared to work hard, and they've got to make sure that they set sufficient time aside. They've got to go through the curriculum and identify what is it they actually need to know. They're probably worthwhile starting with the bits that you're not comfortable with. There's something there about making sure that you apportion time correctly. Sort of practice and sort of maybe in small chunks, sort of, don't think that you have to do 8 hours of revision at a time, because that won't be high quality of revision. So pick a time that seems to suit you, and once you've done that, have a break and then come back to it later on. And something about also circling back to the areas that are harder, whether you come back to your difficult topic 4 months later, or you come back to the difficult question sort of some hours later, or the next day. So and anything else about somebody who's preparing to start revising for the exam?
So there's the general kind of admin related stuff. Just this isn't actually about preparing for the exam, but make sure that you've spoken to your ALCP panel, your TPD knows there's a deadline of application, which is normally 3 or 4 months prior to your sitting, and you have to get 3 structured references done. One has to be your TPD, and this is pan FRCS. 2 have to be recent consultants. Get them sorted out really, really, really early. You used to have to do them on paper. Now they're available online, and they can be just signed and sent back. But they're the other things that you need to be wary of. So when you're sitting down 6 or 8 months ahead, you should be prepping for that stuff as well. In regards to what you're saying, Matt, I used to do like 8 till 10 every night. So I did 2 hours solid work, and then it allowed me enough time to switch off to then come back to stuff the next day and actually work my day job, so to speak. So I would go to work, come home, have dinner, spend a bit of time with the family, put my son to bed, and then I would crack on and do 2 hours. In regards to the section 1, or the EMQs, SAQs, whatever currently is in your speciality, it's just a binary pass or fail on aggregate between both papers. And from that bit, you just need to sit down for a few months and just hammer out the questions. Now, sorry, please, Matt.
Carry on.
No, please, sir.
I was going to ask about the MCQ. So I imagine somebody now, it's a week before their MCQ or EMQ sitting. So what would be your tips for somebody? What should they be doing in that final week before the MCQ?
Yeah, so I did something slightly unusual, actually, in regards to this. So most people, for the EMQs and SAQs, they live in their own little silos. So you end up in this weird scenario where for your part 1, you kind of go lock yourself in a room by yourself with these exam questions you've got off other people, other databases, or paid online. And I actually did something slightly unusual. We had a cohort of me and 3 other friends, so 4 of us. And now it's fairly common for the part 2 to get a group of people together to then do Vive practice together, because you get feedback, which is tactile, verbal, non-verbal, all there in one sitting. And actually you can see how somebody answers something and how you address it. And what's really important is not just the good bits, but the most important thing is their bad bits. So you know what you shouldn't do. And actually the negative feedback is actually more important, I think, than the positive feedback in regards to part 2. So for the reason I mention that is that's accepted as normal practice for the part 2. People don't do that for the part 1. And so what we actually did was we would have, so the week before we all took the week off, basically. We sat down and would do a few hours of our own work. So you do 2-3 hours of your own work, have a break, and then we'd jump online for an hour, and then we would do Teams or Zoom, and for an hour we would go through a question. Somebody would pop up a question on, we'd have either gone through it before or after. We'll then have like a marking sheet. Any question where we all got it right, we just move on. Any question where 2 or more people got it, we went through it properly, if that makes sense. And I found that was a really nice way of doing it. So our day would be get up, 9 o'clock till 11, you do a bit of work, do the exam questions, which we would normally do half an hour, 45 minutes, have a quick break, jump online, hour, bang through it, then have lunch, repeat that, and then do that 2 more times potentially over the entire course of the day. And that's what we found worked. But it's an individual preference thing, and you've got to remember, medics, we often learn from multimodal processes. So if you apply VARC theory of visual, audible, reading, or kinetic, medics don't tend to use one modality. We tend to use multiple modalities. We're often classically multimodal. It's kind of using a combination of what works for you is what I would say, rather than just sitting there looking at a screen and reading stuff.
Can you tell us a bit more about that?
Yeah, so VARC theory is a very classical medical education kind of teaching method. So most people, so let's say we are scholars of English literature. So people in English literature will probably be users of certain modes of learning. So because their information is textual, they won't tend to use other modalities. So in VARC theory, the 4 predominant groups are visual, where you use visual stimuli. So you can use pictures, charts, graphs, etc., or even mind maps. Yeah. Oral is where you use something sound-based to give you feedback. So that could be a spoken lecture. It could be spoken lecture notes. Reading is actually just literally reading the text. And kinetic is using something kinetic, such as a model or something, or a process like that, to actually look at your learning methods. Now, if you were the English language scholar, visual may work, oral will be very good, reading should be excellent, kinetic is probably low in your scenario. Medics tend to be a very broad learning group, so medics don't tend to have 1 or 2 preferences. Most medics tend to learn with 3 or sometimes even all 4 methods. For myself, I'm sure you're aware of this, I'm a dyslexic. I don't like reading as my primary modus operandi for revision. I tend to use a lot of visual. So hence why the mind map that I've sent you for the syllabus and why it was on my wall was because that's what I need. I need the visual stimulus to make sure I've hit all the things. I often would listen to podcasts. So there were a few podcasts available for FRCS revision. There was an Australian group, I can't quite remember them then. And as I was driving to work, I'd listen to those. From a reading point of view, obviously there's the textbooks, and from the kinetic point of view, that was probably the thing I used the least in the part 1, but I used it a little bit in the part 2 for a lot of the descriptors of how you deal with certain situations as a whole. I hope that gives a general background about VARC theory.
Yeah, I think that's really useful, and the key is that I guess everybody learns differently, don't they? And people need to know how they learn, and for that there are online questionnaires that people can do to help them figure out which one they are if they don't already know. But people need to know how they best learn, and then play to their strengths rather than struggling with a learning style that actually doesn't work for them and is never going to work for them.
Well, and I think that's the key of becoming an adult, isn't it? That's what changes you from becoming a GCSE student to an A-level student to an undergrad. At postgrad, you should be nailing that bit, because you've had enough years of lots of higher level education that you should be picking up on those bits of information.
Yeah.
And I think most medics do it well. And I think people who struggle to figure out their mode of learning, they are the people who often get unstuck, unfortunately. And unfortunately, I've had some friends who've ended up in that scenario where they've failed the exams, and primarily I think it's because they've not engaged the way of learning that is best suited for them.
The other thing that I would pick up there is the idea of social learning, and certainly if I think for me when I revised for exam, that was a hugely important part, and I always remember that we would either meet for dinner and we would do both MCQs and Vivas over dinner, or we would go and play badminton and then go and do MCQ and dinner after that. So I do think that probably a lot of us in medicine, we are quite sociable, and certainly I think it sounds like for you and for me also learning with others. I think makes it easier. Yeah, not for everybody, but if you are somebody who works better with other people, who likes learning with other people, then it's a question of finding out who you can practice with. I mean, how do people find others to learn with?
So I think if you're in your specialty and you're a small specialty, it's quite difficult. So I think ped surgery in particular has a real problem of co-learning. And this is because there's 120 ped surgeons in the entire country at any one point in time. So to address the question that you actually asked was, how do people, I think part of it is that you've spent your time being an SHO in effect, or whatever you want to call them this day and age. You spent a bit of your early years as a reg going to courses, conferences, and registrar teaching. What you want to do is find somebody who's like-minded like you and is also driven similar to you. You don't want to have somebody who's a know-it-all and you're not that type of person, or somebody who's really very not pushy at all. So you need to find somebody who's got a style similar. It doesn't have to be the same, because opposites also attract at the same time. But you don't want somebody who's a massive outlier from where you are, if that makes sense. Because if you're the person who's the outlier, who's ahead of the other person, you also don't want to feel like the other person's a burden to you. And I know that sounds quite selfish, but you've kind of got to look at it from both aspects. That's what I'd say there primarily.
Okay. So, and then you're about to walk into the MCQ now. So what kind of a mindset do you need to succeed in an MCQ as you're about to sit it?
Remember to take your bottle of water is the first thing, because as that sympathetic drive kicks in, your mouth will be drier than sandpaper. So that's the first thing I would do. When you go in, you want to clear your mind, and you literally want to remove everything. A colleague of mine who's no longer practicing in medicine and did F2 and didn't get into surgery and packed it in and became a banker, used to have this psychological gambit that he taught me years ago. And on the run up to the exam, on the morning of the exam, I do exactly what he says. And he decants a story in his head where he basically clears his mind. And the story basically is done really slowly over about 10 minutes. But what you need to do is imagine that you are outside on a sunny day, walking through a field. You have to feel the grass on your feet as you're walking, the wind blowing, the sun shining on you. As you go to the grass, you then come to some wheat or some other plant. You then have to walk through that area. You then feel that, and you can feel the tactile change, and you have to imagine all of this. And this is a way to just clear your mind. Then after you walk through that, and you're obviously doing this over about 4 or 5 minutes of just thinking about it, then coming to a little stream with little pebbles in, with water flowing, that you then step on the pebbles, so you get feedback in your head about how pebbles feel. You think about the cold water rushing under your feet. You then walk through this stream, you come out the other side, and in front of you, you see a huge windmill. So you have to portray the windmill and think about all the design carefully in your head. You have to think about how many sails it has, what the architecture's like. You have to think about the door. You can change the door, and it's completely different for everybody. I have a big oak door when I do this, and I have a big handle, but you have to imagine the handle, and you have to think about an engraving on the handle that you feel, and as you can feel it, then you open the door. You walk in, you imagine the room as you want, so that I often have a fireplace on my left side, I have a rug down on the floor, but you have to have a table there. So I always go for a big wooden table, and I have a very large chair for a proportionally sized individual, which comes sit down. And then I have to imagine there's a little box sat in front of me. And as I soak in all the feelings, I literally open the box. And inside the box are a load of cards. On the cards is every single answer to every single question I'm about to get asked. And it is an absolutely godsend, wonderful way to completely clear your mind. But you have to be all in when you do it. You have to ignore everybody else, sit there quietly and just get your mind cleared. And I genuinely do it, and it works beautifully. Because it literally throws out everything that you're worried about. It throws out nervousness, it throws out unsettledness, and it allows you to have a cool, calm head. And it might be just mumbo jumbo, but it works for me. And he told me it years ago.
Yeah, no, I love that, and if I think that kind of that meditation or guided meditation, or I'm not sure exactly what it would be called, but I know that that comes up in lots and lots of different contexts, doesn't it? Whether it's mindfulness or stress relief, but it does work. It does work.
I can honestly attest it works. I never believed him when he told me, and it's always quite amusing because he told me this, as an F2, and 20 years later he doesn't practice medicine and I do, uh,
Yeah.
and I still use it, and I used it for my FRCS, and I use it for any vivas that I go to. And it is a beautiful way of clearing your head.
I love.
Um, because otherwise what happens is, say you're sat in an exam place, and this is more particular for part two more so than section one, um or part one I should say, is that people get intimidated by other people who are there, that you're in this horrible atmosphere which is highly pressurized with a load of people who are actively and inactively intimidating each other, and therefore they're just escalating each other's stress in that place. um but we can talk about that shortly, I'm sure.
Well, let's move on to the vivas then, or the OSCE type. Yep.
May I just say one thing that I forgot to mention about? If you're sitting two parts in your part one, you sit your first exam. When you finish your first exam, obviously you leave the actual exam room and you normally come back to the same table. Try and go get some lunch. You may struggle, but you may want to throw up. But what you do need to do is re-clear your entire mind. Whatever happened in that first exam, if it went badly, you cannot drag that into your second exam, or you will negatively impact your second exam. So you have to clear your mind of whatever happened the first thing, just clear it and get on. And I remember in our exam, the first exam was horrible. The second one was really straightforward. But when we all spoke in the evening, we all said honestly that everybody was really quite distraught as a consequence of the first bit. So that's the only other thing I didn't mention in the part one.
And in fact, I can actually see that also working in vivas and OSCEs, because if you do one station and you don't do very well in that, you can't take that through. If you've got 6 stations, okay, the first one's gone badly. If you take that with you into the other 5, it's just going to be a disaster. Yeah.
Yeah, you can't carry up rubbish with you, basically.
Yeah.
Sorry, Matt. I'll pass it back to you for the next
Yeah,
question.
just if I think of that clearing your mind, I mean, how do you clear your mind in a Viva or an OSCE? Because you don't have a 2-hour lunch break.
So it's probably worth just going through the setup of this part two, because it's the same for all the FRCSs. Before I kind of answer that, section 2 is the pinnacle of being a trainee in any specialty. Yeah, because it's probably going to be the last professional exam that you ever actually sit, unless you choose to do some super high degrees. You've spent many years, lots of time, effort, sweat, tears, lost social weekends, etc., etc. The point of that day is just this. This is the only time in your entire life you get to truly demonstrate why you have spent your time and all that dedication to get there, which is the best part of a decade. Yeah. And this is your time not to show off, but to show somebody that you deserve this. And that's what kind of the pinnacle of it is. In regards to all the FRCSs, they're normally marked independently by 2 examiners who are sat opposite you. They're scored 4 to 8. I know it sounds like a very weird scoring system, but it's a unanimous scoring system across all the FRCSs, which are conglomerated, so they all settle up. So a 4 is a clear fail, a 5 is a borderline fail, 6 is a pass, 7 is a good pass, and 8 is outstanding. And remember, like we said earlier, you're only getting scored on being a first day consultant and kind of nothing more as a whole. All of your marks will get conglomerated and put into a mark sheet, and there is a scoring system. I can't remember the numbers off the top of my head, but in effect, it's 6 times 2 by 8 is the max score, and then you'll be marked up. So the question you were asking, Matt, was how do you clear your time between the Viva? Well, you don't go from one Viva straight to the next, straight to the next, straight to the next. Yeah. I'm just, if I remember correctly, I think my first Viva was at like 9:40. My next one was at something like 11 o'clock. My next one wasn't until 2:30, and then my last one was at 4. So my 4 Vivas were basically split up in multiple parts of the day, and I think the shortest time period was about 50 minutes between them. So you do have enough time to go in and clear your mind and get reset. And you do need to do this. Like I said, I had section 2 buddies, so there's 4 of us as a whole. One of us went in and he did really badly, I think, in the PED section, and it completely threw him because it was like his second section of the day and he couldn't let go of how he did in the second one. But if you don't let go, you will definitely negatively impact yourself further on. Yeah. So I think, doing exactly the same types of things, thought processing, meditation, just clearing your mind. In the exam, like I say, they're normally set in a hotel. So what I would recommend is finding which hotel the exam is going to and making sure you stay at that hotel for the exam. So the second you finish your Viva, just walk straight to your room. Just walk past everybody and just get out of there. Yeah. And your room should be your oasis. And I remember my other half packed me like a survival kit with squash, fruit, sweets, chewing gum, that I had at the side of my bed. And I just went back in there and I kind of cleared my mind, got reset, had a quick look through the bits of the notes that I wanted for the next session. And I'd normally stop about 10 or 15 minutes before just to get my mind back in the same place. That's what I'd say about that. I hope that addresses what you're asking, Matt.
Absolutely. And then we talked a lot about revising for MCQs. What's different about revising for Vivas or for OSCEs?
So, I think the main thing is this is 100% a team sport, not a singular activity. So I know we both insinuated at part 1 you can do that. So I think what you need to do is you need to have your section 2 buddies, as I call them. I think there's a golden number, and the golden number is 2 to 4. I think anything less than 2, which means you're singular, then you're just a lone wolf and you're not seeing any feedback from anybody else. Once you get into more than 4 people, that's too many people. I think 2 is fine as long as you get on with that person. You will spend so much time with that person, you will get annoyed with that person. And if you're really good friends, you'll find that revising through FRCS, you'll probably spend 6 months where you don't really want to see that person outside of, work or any other place. 3 is good, but sometimes people can feel like a third wheel. 4 is good, but it is the upper size limit, in my opinion, of doing this. Once you get into 5, I really think you should be splitting into 2s and 3s, because if you're getting down for, say, Viva practice online on Teams, Zoom, or whatever, if you think the numbers through 2, 3, 4, one person will normally ask the question, the other person will address the question. So with 2 people, it's just bang, 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 bang. So there is no downtime. So you're either getting examined or you're examining non-stop. Your entire time is really quite intense. If you stick 3 people in the mix, you get some downtime because you do your exam, you're then the examiner, then you have a break, and it just rotates. And therefore, your brain gets a bit of time to refunction. And actually, I find that more efficient. 4 is good because it gives you 2 times when you're being examined versus not, and then 2 times when you're not. But once you're getting to 2 times when you're not, that number on a regular basis means that 50% of the time you're not actually using your brain, you're watching other people. But like I say, that feedback from seeing them is really, really good. Now, remember, you're going to be doing your day job as you're revising for the exam. So people are still going to be doing on calls. And if you work a 1 in 6 or 1 in 5 or a 1 in 8 rota, and you're all, say, on the same rota, there's going to be multiple times people can't make it. So the reason why 4 worked for us was in a week, there'd be 3 days of the week where one of us would be on call. So actually, most of the time, or even 4 days of the week, there'll be somebody on call. I apologize. You'd find most of the time 4 would end up becoming 3. And in a week, we'd normally become 4 once or twice. And occasionally it would become 2. Whereas if you've got 2 people, when you're on call, you're not visible. When the other person's on call, you're not visible. 3, you get a kind of a bit of a mishmash of both. But what happens is when that person's on call, they get a load of FOMO, fear of missing out, and they really, really dislike the other 2 people vibing without them. Whereas with 4, it's a lot less noticeable, the FOMO. primarily.
Mhm.
I know that's a very long way of saying 2 to 4, but that's the reasoning and the rationale. But I have thought about it for a long time.
Yeah. And the key then really is it's get together with your colleagues, find consultants that can give you Viva practice, ROSCE practice, and practice, because by that stage you've already read all the textbooks and you've done all the knowledge learning for the MCQ. So all of that knowledge learning should more or less be there. But the essence of the part 2 is practice, talk.
And you spend enough time being on call in your specialty that you'll gain loads of practical experience. It's just being eloquent enough to roll off what you need to say and do. So when you pass the part 1, you normally have under about 8 weeks, normally sometimes 6 weeks until your part 2. So they normally take 4 weeks to tell you, and then normally you've got about a 6 to 8 week window before you actually can sit your exam. So what I would recommend is post part 1, clear your schedule for 2 weeks and just forget about work. Go on holiday, spend time with your family, remember your loved ones. Then, as you're coming down, waiting for your exam results, start planning the next stage ahead. So, my rule of thumb for full days is spend a half day doing Viva practice with either a consultant, a fellow, or a post-exam SPR. Make sure you have a break, yeah? Then do some buddy time. So, you can either do that front-loaded or back-loaded or whatever. In a full day, if you've got the full day working, do not spend more than 8 hours working, because you will burn out. You'll get information overload. You'll start being less sieve and you can't remember simple information. And remember, even though I say it's only going to be 8 weeks, it's a marathon. It really isn't a sprint. I've seen people hit it so hard in the first 3-4 weeks that they then literally just can't function, and then they spend 3 weeks just going, ugh. And you don't want to do that. Yeah. You need to give yourself time to run up to the exam and stop peaking too early. And that's what I'd say. And I've still got my actual exam calendars. So I can tell you this. So my exam was on the week of the 19th of October in 2018. And I remember looking through this, and I'll just run you through this. So the week of the 24th of October, I was on hot week, so I was on call for 7 days. I then finished, and one of my colleagues, Sam Cho, covered my Sunday so I could drive up to the Dundee FRCS course. I went and got grilled for 3 days at the Dundee FRCS course, and then drove back to Nottingham to go to a specialist neurofibromatosis type 2 clinic. I then had a medical procedure because I needed an injection in my spine the next day. I then had Viva practice with 2 consultants. I then the following week went to the audiologist service. I went to the skull base MDT. I met up with Julie McGlashan, who's a laryngologist, and Sarge Mansouri is a head and neck surgeon. And then I went off to Birmingham for their course 2 days later. And then the following week, I did some speech and language therapy. I did some time with yourself, Matt, with pediatrics, plus Reprovan. And then I went off to a dissection course. I then came back and I had another week on call. I did nothing that week. So in the middle of my run up to my exam, I actually had a week where I didn't do anything apart from 2 hours every evening. And that was really nice to kind of decant and not overpressurize yourself and not be overstressed about doing excesses. Because while you're working, you're on call, you're actually doing a lot of this. You're just not doing it in a formalized way. I then continued, went to a FES course, and then basically I had 2 solid weeks of just Vivas, with lots of different consultants. And that's the way that I did it. But I ended up with, I think it was 8 days just looking at this, where I didn't have anything, but I did something right in the middle. The other thing I would say about courses, and obviously this depends on your speciality, is courses are a bit of a double-edged sword. Just by going on a course doesn't necessarily mean you're going to get taught everything that you need to know for the exam, but it's learning to use it to get to your endpoint as you need to. Don't go on too many courses, and don't be lulled into the false insecurity that a course overtakes practice. Because practice is the key. But the course is a really good way of trying to figure out the level that you should be hitting at it. In regards to the actual delivery of your Viva, and this I find is true across any specialty, you have one examiner, they're asking you 3 questions. They then pass over to the second examiner, they're asking you 3 questions. as college rules, they have to physically get through 3 questions each. If they do not get through 3 questions, they breach your exam. Yeah. So they will be really time stringent and they will get you through it. So you've only got 5 5-minute slots 3 times and then 3 times again. I have what I class as golden rule for the 5 minutes. Yeah. The opening statement is literally your pass fail. You need to get rid of this quickly and efficiently, and you need to do this in under 60 seconds. If I asked you about a patient turning up with stridor, you could sit there and you could talk for 3 or 4 minutes about that. But by talking about 3 or 4 minutes and asking about the minutiae of have they have tracheal stenosis, have they had any cardiac conditions which could give a cardiac sling, have they got any reasons that they've got bronchiomalacia, have they had bronchitis as a child? By just saying those things, yes, it shows that you know knowledge about it, but actually you're not gaining through that really quickly. So if you spend 3 or 4 minutes to get on that question, rather than just a quick diatribe / organizational answer in a minute, yes, you may not run through all those tiny minutiae, but it shows to the other person that you're safe, you're efficient, and you want to get to the next questions. The opening question is a pass-fail. To get your next marks, you need to get to the next question. To get the big marks, you need to get to the next question. There was always a minimum of 3 stems. Sometimes it can be as much as 5 stems, but all of the questions will have stems. But if you don't get to the stems, you can't get the marks. So your opening stem will be your 4 to a 5 or a 6. Your next 2 minutes is your next question. You want to bash that out and keep on moving on. That gets you 5, 6. Your last minute should be where you're pushing for your 7s and 8s, where you're talking about high level functioning, high level learning, high level organization. Yeah. And if you don't proceed and progress, you ain't going to get those marks. Yeah. So you might pass, but you won't do well. And that is the crux of your answer structure to get those mics. Because if you don't know the rules of engagement and you don't know that actually, I could tell you the absolute minutiae of this first bit and it's impeccable, but they can't actually give you the continuing marks because you never got to the question. Often people don't word that in any way, shape or form, and people just overlook it and they think, I need to get everything. You don't need to get everything.
So big pictures first, get to the nub. What's this question about? Get to it straight away. So probably my final question, Bindy, what would be your top tips for a doctor that's coming up for exams?
I've got 6 tips. Tip number 1, practice. Tip number 2, practice. Tip number 3, practice. Tip number 4, it's not practice. It's a team sport, not a solo game. So for your part 2, do your buddy thing that we talked about. Tip number 5, which is something that massively gets overlooked, is all the FRCSs have a clinical component. Everybody spends their time talking about the vivas and people forget to do the examination bit. And I remember with our buddies, we got together in Leeds one weekend, and over 3 days, Friday, Saturday, Sunday, we met every day. We had a clinical where we would say do an ear, would get the person to go through the examination, they'd talk through what they were on to examine. If, let's say, it was a glomus tumor, when they said, can we look at the drum, we'd then show a picture of the glomus tumor, then they would respond appropriately, and then we'd ask questions. Remember, the clinical is an excuse for a viva in a different format. That's all it is. But you need to run through it, because if you're not slick, it's obviously not slick, if that makes sense. Yeah. And make sure you can do tuning fork tests, and make sure you can describe, free field testing. Yeah, especially if you're asked. Yeah, just those really, really subtle, simple things. And make sure you can do a septal rhinoplasty assessment. One of your rhinology questions will be a septal rhinoplasty assessment. They will show you that. That is always one of the questions, and that is the most common clinical scenario for the I'm sorry, I'm going off on the ENT front, but this is the same in other specialities. Yeah, in general surgery, there's always a hernia. Yeah. My 6th thing is something that somebody who said to me many, many years ago. I've always looked up to this chap in regards to the exam, is aim for gold. Then if you slip, it really doesn't matter because you still passed. And if you don't quite reach the top, you're fine. If you aim for a pass and you slip, you'll end up like I did for the MRCS. and you'll end up failing by 1 mark the second time. Whereas you should aim for gold, and you should only miss 1 mark in the exam. And it doesn't matter if you make a big slip then, because you've got the wiggle room to slip. And that's what I'd say.
Wonderful. Thank you very much, Bindy.